And then we were, oh, there we go. Recording in progress. And then we were fortunate enough to match her here at LACUSC for her internal medicine residency. Following that, she did fellowship here. She picked up an MPH along the way. And last year, she was awarded the Faculty Teaching Award for rheumatology. So I am very excited to hear what she has to tell us about DMARDs for the internist. Thanks very much, Leanna.
Great. Thank you, Jen, so much. Excited to be here and go over this talk. Just as a little aside, I was supposed to be giving this from my office, but my son is sick, so I'm home with him. Thankfully, good news is he's napping right now. Bad news is probably not for long, so I may have to grab him quickly and then come back, but he's a very chill baby, so shouldn't be an issue. But
he'll learn all about DMARDs too.
Yeah, and he actually likes the computer, of course, like all kids, so he'll just be staring at the screen. But again, such as working from home and part of life right now. Alrighty, so we're going to go over, actually, let me minimize this. Okay, so we'll go over today a talk I have entitled DMARDs for the internist. And this is from the perspective of a rheumatologist, which is kind of like obvious, but I also wanted to point out that a lot of other specialties use DMARDs. And we'll go over this a little bit later in the presentation, but I'm giving this from the perspective of a rheumatologist rather than a dermatologist, gastroenterologist, etc. Principles will still be the same, but probably there are some differences. All right, these are my disclosures. So our objectives for today, we're going to describe the general rationale of DMARD use for our systemic rheumatologic diseases. We're going to talk about special considerations for starting DMARDs, stopping or changing, and kind of how that wraps into the patient's overall clinical case. We're also going to increase awareness of particular safety concerns. I'm going to focus on infection-related safety concerns, and we're also going to talk about some basic monitoring of some of our DMARDs and how we use these from a day-to-day perspective. So what is a DMARD? DMARD, it's just an acronym, disease-modifying anti-rheumatic drug. In the world of neurology, you'll often see this as DMT, which is disease-modifying therapy, and it's essentially the same principle. It is a drug that we use in order to affect the rheumatic disease. A lot of people will think that it's kind of equivalent to immunosuppression, but it's not actually fair to say that DMARDs and immunosuppression are exactly the same. There's some DMARDs that are considered to be mostly immunomodulating, so they don't actually lower the immune system. And even for those that are considered to be a bit immunosuppressing, they're not necessarily immunosuppressing for all individuals. For some, they kind of bring the immune system back to a happy medium. So while immunosuppression is a decent term to use, it's not exactly correct for all DMARDs. We use DMARDs in addition to steroids to control underlying immune dysfunction. And the way I explain it to patients is that steroids are just extremely indiscriminate. And I think I give this analogy of the garage of a house being on fire. If the garage is on fire, you call the fire department, they come, they bring their hoses and they spray everything. The house is going to get wet, the garage is going to get wet, the yard is going to get wet. It doesn't really discriminate. It's just there to put out the fire, and that's what the steroids are like. And then when I think of DMARDs, though, I think of an agent that's controlling the cause. And I think, why did the fire start? Maybe it is an electrical issue. Maybe there's dried leaves in the gutter or some other issue. And the DMARDs focus on that. And so we use these DMARDs in addition to steroids very, very often. The steroids will work quickly. They'll control the fire, control the inflammation, but then we bring the DMARDs on board in order to minimize steroid use. And because of that, they're often called steroid-sparing agents. I think this term is pretty good. You could argue this for many patients that they're steroid-sparing agents. There are some individuals who we can't get off of steroids, but at least we're steroid minimizing then. A lot of our DMARDs were actually taken from the world of oncology and transplant literature. Some were developed specifically for autoimmunity, whether it's gastroenterology, rheumatology, neurology, dermatology, and some other conditions as well. You also see like hepatology use DMARDs for autoimmune liver disease. So we're kind of looking at a pool of medications, again, some that were developed specifically for our diseases, but some that were actually pulled from particularly the world of oncology and transplant. It's a very heterogeneous group of medications. We tend to think of them kind of on a spectrum of mild in terms of their immunosuppression or their side effects, and others that tend to be a little more potent and naturally then potentially having more side effects. So there's a big spectrum of what we can use. And it kind of depends on the clinical situation of the patient, what we're treating, what symptom we're treating, that helps us to guide what we're going to use for that particular situation. A long time ago, a surgery resident felt that what we were doing was just kind of magical. He said, you just see these patients and you kind of sprinkle something on them and they get better. And I really, I think as internal medicine physicians, we know better, but for a lot of physicians, DMARD use is very mystical or mystifying. So again, kind of bringing this home, what do we do with these patients? What's the rationale for what we use? I like the Yoda idea and using the force, but again, there's a lot of rationale for what we're doing here. So our goals for DMARD use, I kind of sat down and thought of this, I think some of these are very, very obvious. Even the obvious ones though, even the ones that are not as obvious, there's very clear rationale for why we do certain things. And sometimes I don't feel that's always reflected in, say, writing a note. We don't necessarily see, okay, well, why are we starting X, Y, or Z? So we want to control the disease acutely. That's a very obvious one. You have a patient with rheumatoid arthritis, they can't use their hands well. We want to help them become more functional, make dinner, do their ADLs, stuff like that. We also want to prevent long-term damage, and damage in rheumatology is defined as being chronic, irreversible changes. This one, I think, is one of the more subtle goals. So a patient will say, hey, I feel a lot better. Why aren't my hands, or let's say my wrist, why don't I have good range of motion of my wrists anymore? I feel well. I don't have any pain. I don't have any swelling. I don't have any redness. I don't have any fever. I've gained back the weight that I lost because I was so ill. Why can't I still move my wrists? And with rheumatoid arthritis patients, that's actually due to potentially some chronic damage that will never be reversed. And we want to prevent that. I'm using rheumatoid arthritis a lot throughout this presentation as a good example, but one thing that you can see in advanced rheumatoid arthritis is ankylosing of the wrist. So even when we get this patient in our office, if they've had uncontrolled disease for a while and we put them into remission, they can still have damage that, again, you can't reverse. And that's why it's important to get these patients into remission quickly and early in the disease process. As I've already alluded to, we also want to minimize steroid use. I'm not going to go over the adverse effects of glucocorticoids. We all know what they are. Tons and tons of patients will have at least, psychiatric complaints, weight gain, cosmetic issues. Patients, generally speaking, do not like being on steroids. We also want to reduce or eliminate non-rheumatic disease comorbidities. And what I mean by this is that there's a lot of different comorbidities that go hand in hand with our diseases, in particular cardiovascular disease. There's good data showing that when we use TNF inhibitors in rheumatoid arthritis, we actually decrease cardiovascular risk long-term. This probably has to do with decreasing subclinical inflammation, but there's actually data too showing that it decreases atherosclerotic plaques. So really important, even if, say, the patient feels quite well, but maybe you think that there's some uncontrolled inflammation, that's actually why we might change DMARDs, because we want to say, even though you feel well, even though things are looking better, that persistent inflammation still increases risk of cardiovascular disease, strokes, heart attack. So we want to make sure that those patients are well controlled, not only from a rheumatic disease perspective, but also so that their other comorbidities are also treated or prevented. And then finally, potentially most importantly, we also want to increase quality of life and patient-reported outcomes. This is, easier said than done. There was a large meta-analysis looking at some qualitative data from lupus patients, and the biggest two unmet needs in lupus are pain and fatigue. And those are usually unrelated to disease activity. And it's been thought that we actually don't have the right outcome measures for a lot of our lupus trials. They don't really take into account patient experience with the medication. So we want to make sure that we're using meds that increase quality of life, improve patient-reported outcomes, and affect the things that patients care about: pain, fatigue, sleep quality, mental health, stuff like that. Not every disease is going to have 100% control of all these more softer sides of medicine, but we still want to take the patient's word into account. And sometimes some of our medications can even worsen quality of life, even though it controls the disease. So again, we want to make sure we're trying to find the right DMARD for the right patient, and then trying to hit all 5 of these goals. And then going back to just what the acronym is, disease modifying. So we're modifying the course of the disease. We want the patient to go into remission. We want to reduce the risk of damage, use minimal steroids, reduce the risk of comorbidities, and improve quality of life for the patients. So we're going to talk a little bit about the different categories of DMARDs. We've broken them up into kind of three main categories. Conventional DMARDs, which I've abbreviated as CDMARDs. You might see some abbreviated as traditional or TDMARDs, but usually we use the term conventional. Most of these were taken from the oncology and transplant world. The names might look quite familiar. A lot of them are a little on the older side. They're almost all oral as well. Biologic DMARDs or BDMARDs, biologic medications basically derived from living tissue, and they're super, super costly to purify and manufacture. So they're very rarely a first-line treatment. And then also a newer category called oral small molecules, and then just a wastebasket, et cetera, category we'll go over briefly. So this is just a little visual of the medications that we use that fall into the DMARD category. As you can see there on the left, we have a lot of medications, again, very heavily derived from transplant, from oncology. The only one on that list that was developed specifically for rheumatologic patients was actually voclosporin in the calcineurin inhibitor category and sulfasalazine for rheumatoid arthritis. But everything else here, everything else here was borrowed from the transplant or oncology literature. Most of those in the conventional categories, you can see there are PO, but we can give cyclophosphamide IV as well. And I think the big elephant in the room, but the outlier, I guess, in this category is cyclophosphamide. Generally speaking, when I look at this list of conventional DMARDs, I think of drugs that are a little more on the mild side. Definitely, you can get major side effects and very concerning drug-drug interactions. But generally speaking, the conventional DMARDs are going to be a little less immunosuppressing, with the huge exception of cyclophosphamide. So just keep that in mind. Biologic DMARDs are in my orange box here. These are a pretty heterogeneous group of medications. They're all given either sub-Q or IV. There's no oral formulation of these. And these inhibit a variety of different molecules and cytokines. Most of these are monoclonal antibodies. I did not list that as all being monoclonal antibodies because there are some that are fusion protein antagonists, but these are the cytokines that they inhibit. We'll focus a little bit on TNF inhibitors, which is the first category here. These are used really frequently in rheumatoid arthritis and psoriatic arthritis, and then off-label for other diseases too. Then the oral small molecules, as you have with the name there, they're all given PO. JAK inhibitors, a very, very new category called TYK2 inhibitors. I actually have not even used any of those yet. And then apremilast, which is an anti-PDE4 inhibitor. And then in the bottom here, I have et cetera. NSAIDs, glucocorticoids, IVIG, and plasmapheresis are technically all DMARDs, but we don't really define them as such. So they all will modify the disease to some extent. Even glucocorticoids, as toxic as they are for both rheumatoid arthritis and psoriatic arthritis patients, it will decrease their risk of having long-term joint damage. So yes, it does modify the disease technically, but we don't usually consider them to be in the big scope of DMARDs because one of the big points of DMARDs is to minimize steroid use. But again, both NSAIDs and glucocorticoids are technically disease modifying. IVIG, plasmapheresis, usually used in the more acute setting or in the short-term setting. I'm not going to go into those in depth, but again, they do kind of fall into this et cetera category. So when I look at a patient and I think, okay, what do we need to give this patient? The first thought is, what disease are we treating? I think that's kind of the easy part of just saying, all right, you have lupus. What are our lupus options? You have psoriatic arthritis. What are our psoriatic arthritis options? But then you want to go a little further and think, what symptom are we treating? Because not all symptoms of a disease or symptoms of a patient with a disease actually need a DMARD. A good example might be something like systemic sclerosis, where they're having horrible esophageal reflux. You're going to treat with a PPI, not a DMARD. Unfortunately, systemic sclerosis doesn't have a lot of treatment options, but for the esophageal reflux, maybe for a lupus patient as well, you're not going to give Benlysta for something like that. You're going to give a PPI or something, maybe referral to GI for some mechanical issues or thoracic surgery or something. So I just want to be careful here. Uncontrolled disease does not unequivocally mean that they need more DMARDs. And then along the same lines there, I'm also going to think which DMARD is best for that particular patient in front of me. These are the four things I think about when I look at each patient as an individual. I'm going to look at what other comorbidities do they have, perhaps another autoimmune disease. Maybe they have CHF, maybe they have chronic kidney disease, and that's going to play a role in which one I choose. There's some medications that exacerbate CHF. There's some medications that have to be dose reduced in CKD or not used at all, et cetera. Then I'm also going to look at the side effect profile. I have a young woman who is very inconsistently using contraception. I want to stay away from teratogenic meds if possible. If I have patients who maybe have uncontrolled diabetes and I'm scared that they're at very high risk for infections, I'm not going to use a drug that's classically associated with a very high risk of opportunistic infections. And of course, medication interactions also need to be considered, some more so than others with certain medications. We'll talk a little bit about that later on. And then also lab monitoring. Some medications need very frequent labs on the order of every 6 to 12 weeks. Not surprisingly, a lot of patients don't want to do that. So I might tend to use a medication, if it approved by insurance, that requires maybe labs just once or twice a year. So we'll talk a little bit about some principles here. When you see a patient who has a rheumatologic disease, it seems like sometimes, oh my gosh, there's so many medications they could be on. Generally speaking, the way that we look at these patients is we use 1 or 2 conventional DMARDs plus a biologic DMARD or an oral small molecule. So going back to that slide, again, maybe 1 or 2 of the ones in the conventional DMARD group, maybe 3, depending on the patient and the situation. And then we'll add either a biologic or an oral small molecule. You will almost never, ever, ever see a biologic plus an oral small molecule together. These are almost mutually exclusive with very few exceptions. I think there's some gastroenterology literature showing you can combine a JAK inhibitor with, I think, an IL-7, IL-23, but we really do not do this in rheumatology. So again, they're almost mutually exclusive. 99% of the time, you're not going to see a patient on both a biologic and oral small molecule, but you can combine one of either of those with a conventional or even a handful of conventionals. We have a patient who, let's say we start on adalimumab, which is a TNF inhibitor, and they have 0 response at all. That's considered a primary failure. We're going to jump immediately out of that category. We're not going to try other TNF inhibitors. A secondary failure, though, which we see in some patients, is when they do have a decent response or perhaps even a really good response, but that really good response is only temporary. Perhaps they go into remission just for 1 year or so, or maybe we get 50% control, give or take, but we're not quite as well controlled as we want to be. We can either increase the amount of that medication, provided that there's room for doing that, or we can switch to another medication in that family. So let's say we do start adalimumab for rheumatoid arthritis. They get into remission. 9 months later, they come in, more swollen joints. They're not feeling well, lots of morning stiffness. We can actually explore all the other TNF inhibitors rather than the first situation in which adalimumab failed immediately. We wouldn't look at the other TNF inhibitors. So just giving a little rationale into why we choose meds and how we switch if we need to switch for these patients. A lot of our medications, particularly the newer ones and the biologics, do have FDA approval for different diseases, regardless, psoriatic arthritis, rheumatoid arthritis, but we still use a ton off-label. A big part of that is due to the fact that we treat relatively rare diseases. So maybe something like familial Mediterranean fever, giant cell arteritis, particularly when these patients become recalcitrant to treatment, we have to kind of pick and choose and just look at the literature and see what's supported by the literature. So we don't always have FDA approval when we're using these medications. Even for lupus nephritis, the vast majority of medications we use for lupus nephritis are not FDA approved. There's actually only 2 that are. And prior to the approval of those 2, which only happened in the last few years, everything else was off label. We do have generally evidence-based guidelines for their use, and we do look at these guidelines. And I say somewhat evidence-based because a lot of it is expert opinion. And as you sort of go down the line with these medications, let's say a patient's failed 1 or 2, or it's a very medically complex patient, there's a lot of gestalt that comes into play. Then it's not that you just have to march forward with a certain algorithm or a certain treatment plan. You involve the patient, you look and see how they're doing, take into account, say, concurrent fibromyalgia, stuff like that. But generally speaking, we do have pretty good guidelines for use of DMARDs in our main rheumatic diseases, rheumatoid arthritis, lupus, and then the vascular disease as well. Again, we're also treating some very rare stuff too. So sometimes you'll see these patients when, I mean, you're just kind of in the wild west of treatment. Maybe say a very advanced adult onset Still's case. And there are some FDA approved medications for that, but a lot of times you're sort of looking at the literature, making sure that these patients who say have chronic kidney disease or something else, you're going to have to very carefully look at the options for those patients. Okay, moving on to the idea of infectious risk in our patients. Almost all of our DMARDs do carry a slightly increased risk of infections in the short and long term. Both normal or just your kind of bread and butter infections, maybe some sinusitis, UTIs, but also more scary opportunistic infections. Every single infection, or the risk of every single infection, is exacerbated when you're concomitantly using glucocorticoids. And I think that's a very obvious thing, but I actually really try to drive that home with patients. Maybe they, you're watching TV and they see an ad for adalimumab or certolizumab, and they say, oh, those medications sound terrifying. You have the risks read really quickly at the end of the commercial, really fast, and they're very scared. Oh my gosh, these are horrible side effects that are going to happen to me. I'm going to get some horrible infection. And some patients are actually very resistant to go off of their steroids or lower them while I add something like adalimumab. And I really try to drive home the point that yes, it sounds scary. Those are scary or worrisome side effects that can happen. But at the end of the day, staying on glucocorticoids is far, far worse. For many reasons, short-term, medium-term, long-term. I do not want my patients on steroids long-term. So I think that's really how I try to explain it to the patient. Yeah, we do have a slightly increased risk of infections when we start our medications. It's generally dose dependent. It's generally earlier on in the treatment course, but really at the end of the day, if you're on glucocorticoids as well, particularly more than 7.5 or 10 milligrams of prednisone a day, that's really where the infectious risk starts to rise. And so I explained to them, I want to get you down off of the glucocorticoids. This will help me. Yes, the commercials, in the end of the commercial in particular, it reads all those risks very fast, sounds scary, but it is not as worrisome as being on long-term steroids. Now, that being said, there are two medications that actually do not increase the risk of infections. Hydroxychloroquine, which is an anti-malarial we use in lupus, and then apremilast, which is an oral small molecule that we use in psoriasis and psoriatic arthritis. So if someone is, say, truly terrified, or let's say a surgeon or probably a surgeon says, I want you off of your immunosuppression, I can actually very confidently say before that surgery, we can continue hydroxychloroquine or we can continue apremilast because they're not actually immunosuppressing. And then two big timeframes I'm going to divide as part of this presentation into is what do we need to do before we start the DMARDs and what do we need to look for while a patient is on a DMARD? A lot of times the patient will actually come to their primary care doctor or maybe an urgent care before they actually come to us with a new symptom or something. And so I think it's helpful to know what things can we look out for these patients when they're on the DMARDs. And we'll go over some of the key ones in detail. So before DMARD initiation, so this is maybe a new diagnosis of rheumatoid arthritis. Maybe they are on some low-dose prednisone from their primary care doctor, and I say, we're going to start medication X. Maybe they want to go home and think about it. So what I'll usually say during this time is, okay, totally fine to think about it, but let's get you up to date on your vaccinations before we start pretty much anything. All our medications, in theory, will reduce the response to vaccines, some more so than others. And really, at the end of the day, if the patient hasn't gotten their vaccines, we start the DMARD, I still get them vaccinated. It's not that, oh, I'm not going to vaccinate at all now that you're on this DMARD. We'll still vaccinate, but in theory, it's better to do before they're on it. A lot of data has come out from the pandemic about which medications are the most problematic in terms of blunting the vaccine response. And it's actually rituximab and mycophenolate, rituximab much more so. With all of our DMARDs, we do not give any live vaccines. Probably the only exception is hydroxychloroquine, again, because it's not immunosuppressing. But we do not give any live vaccines at all. You'll want, if you do have to give a live vaccine before the patient's on a DMARD, you do wait 1 month. Before we start the patient on a DMARD, we'll also screen for hepatitis B, latent tuberculosis, and of course, a urine pregnancy test as well. There's some data that suggests that if there's risk factors, consider doing COXI serologies. So if a patient's lived in Central Valley for a long period of time, or really, I guess, any period of time, or maybe they said they have a history of valley fever, go ahead and see if there's any evidence that we need to actually pursue further treatment rather than starting one of our meds and then seeing something terrible develop down the line. We've seen COXI, outside of Central Valley too. There's no perfect guideline for what to do with that, but I do actually just try to ask my patients, a significant exposure, maybe at a construction site where you're getting a lot of potentially fungal material inhaled. I had a patient from Simi Valley who had bad COXI. So again, this is kind of provider gestalt about what you're going to do, but this is something that we think about when we are looking at these patients in addition to what I have mentioned there. And of course, before we start, we'll also talk about family planning. Do they want to have more children, and what are they using for contraception? Okay, so let's go into some of the specifics with our DMARDs. So patient says on any of these, I just want to give a little bit of a very much bird's eye view. What do we think about when we see these patients, particularly when they say are floating through our resident clinic and the resident just pops in and out, and what do I try to drive home with that resident who may never see a patient on that medication again? So for hydroxychloroquine, again, this is an anti-malarial. We use a ton in lupus. Pretty much every lupus patient should be on this. Rheumatoid arthritis patients and some undifferentiated patients will also be on hydroxychloroquine. The biggest side effect we see that is concerning is retinal toxicity. So hydroxychloroquine will cause pigment deposition on the retina. And thankfully, that pigment deposition is asymptomatic when it first starts. So you can actually screen for it and you can see it before the patient will have any visual field defects. Now, that being said, this does not happen until bare minimum 10 years after starting. So what I will usually explain to patients here, if you have a little bit of a floater or a little bit of blurriness or a little bit of eye discharge or something, this is not the hydroxychloroquine, especially early on in the disease. Even then, after 10 years, it's very much dose dependent. It's very much dependent on other risk factors, including chronic kidney disease and obesity. So if you're dosing this appropriately, the risk of retinal toxicity is actually quite low. So I go into that quite a bit with patients because that is very concerning, the idea of, oh my goodness, my eye health could be compromised here, but it's very rare, all things considered. And again, it's dose dependent. And if you're using it correctly, you should see this very rarely. There's also a risk of skin hyperpigmentation. This is not actually that dose dependent. So some patients will complain of just a generalized kind of like melasma looking side effect, but it can occur anywhere on the body, not just on the face. This is also quite rare. And then it just can have a lot of other random side effects too that you can see with pretty much any medication, a little bit of a headache or dizziness, a little bit of stomach upset. When I see these kind of non-specific side effects, for the vast majority of patients, they go away within a week. These should not be long-term issues for patients. What's really nice about hydroxychloroquine too is that we actually do not need to check any labs frequently when they're on it. The only thing I will check is maybe an intermittent serum creatinine, because if they do have chronic kidney disease, we have to lower the dose.
Hey, Rune, how you doing? All right. So there's just one patient. I just kind of wanted to just confirm things and just learn things myself. So there's a patient that.
Thank you. Okay. Moving on now to some of the medications that we see, again, borrowed from the transplant world and oncology: azathioprine, methotrexate, leflunomide, sulfasalazine, mycophenolate. These meds are a little more toxic. We're actually going to be looking at their liver enzymes pretty frequently when they're on them. And with all of these medications, they can have a lot of gastrointestinal side effects, particularly diarrhea, some weight loss sometimes, and then leukopenia is also frequently seen. The leukopenia doesn't mean you have to stop it. Even an LFT bump, you don't necessarily have to stop the medication, but you just want to keep a close eye on it. Some of these more than others. Sulfasalazine is really well tolerated, usually doesn't have quite the degree of toxicity as, say, high-dose methotrexate, but you can still see it. So we'll check labs pretty frequently, especially early on when patients are starting one of these meds. And then methotrexate and leflunomide are very well known for causing hair loss, and then oral ulcers as well with methotrexate. But I've seen pretty profound hair loss with both. And so, you know, understandably for particularly women, but for men too, if you're, you know, come in and they feel like they've lost a quarter of their hair, they're not going to want to continue the medication. So moving on to calcineurin inhibitors, again, a medication borrowed from the transplant world. We see a lot of neurotoxicity, maybe just a little bit of a resting tremor, and that can still be very distressing to the patient. But then a more severe side effect can be press, pretty rare. And actually, when we use these medications in lupus patients are already at high risk for press. So it's not necessarily the medication, but we do see it occur at slightly higher rates when we use calcineurin inhibitors. And then also a lot of metabolic side effects with calcineurin inhibitors, particularly worsening of hypertension, hyperlipidemia, new onset diabetes in a patient who's never even had like prediabetes, and then also cosmetic side effects of hirsutism and gingival hyperplasia. You see that much more so with cyclosporin A rather than tacro, but you can see that with tacro too. Tacro tends to cause a lot of the hyperlipidemia and new onset diabetes. I believe it's actually like it causes pancreatic cells, it causes actual apoptosis. And then also these calcineurin inhibitors tend to interact with a lot of medications. So starting other medications, azoles, antifungals, HIV medications, and other medications have significant drug-drug interactions with CNIs. You also will see sometimes calcineurin inhibitors decreasing the GFR. This is not necessarily true nephrotoxicity, but because calcineurin inhibitors are a bit vasoconstrictive, hence the risk of hypertension and press, it's more of actually a flow issue. So if they're vasoconstricting the afferent arteriole, you're going to see a little bit of a GFR decline. And for the most part, that stabilizes. It should not be a radical GFR going down, 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 down. This should bump down maybe 3 to 5 points and then stabilize. We don't see these side effects quite as much with voclosporin use. And then cyclophosphamide is really kind of falling out of favor with a lot of rheumatologists. There's so much good data showing other medications that we can use instead of this for lupus nephritis, bad ILD, et cetera. But this unfortunately still needs to be used in some patients. And this is a tried and true classic chemotherapy. So we see a lot of side effects with this, pretty significant hair loss, gastrointestinal complaints, diarrhea, weight loss, then a risk of hemorrhagic cystitis and bladder cancer, along with secondary malignancies. So these patients actually, even once they complete their cyclophosphamide treatment, they're still at risk for down the road lymphomas and bladder cancer. And so we'll actually do pretty frequent UAs on these patients, maybe once or twice a year if they've ever been given cyclophosphamide, and then just keep our eyes out for any sign of, say, a lymphoma or leukemia. Both of those are somewhat dose dependent. And so if a patient just had a really low dose, we use lower doses for lupus nephritis if we can get away with it. But for some patients, particularly those who were treated, maybe say 20 years ago, 15 years ago, where they used really, really high doses, those patients worry me more. All right, let's move on to TNF inhibitors. We use these guys a ton. These are our mainstays of treatment for both rheumatoid arthritis, psoriatic arthritis. We use them off-label for Behçet's and a variety of other conditions as well. So the biggest risk that I think about with my TNF inhibitors are actually TB reactivation. The patients with latent TB, any kind of granuloma, the granuloma is actually, this is the wrong terminology probably, but it's kind of held in place by TNF. And so if you actually give a patient a TNF inhibitor, it allows the TB organism to spread much, much, much more easily. So even when a patient says, I had latent TB in the past and I was treated, but we're not really quite sure, we'll still usually either get public health record or get infectious disease on board, just because the risk of disseminated TB is so great if they have not been fully treated. It doesn't mean that you can't use a TNF inhibitor. It's just you have to have a lot of due diligence with making sure, especially in a population that is at high risk, that you're asking about prior TB history, getting a quant gold or a PPD, something like that, and then making sure you're starting this carefully. The rest of the things in this list are actually all pretty rare, thankfully. So we do see a slightly higher risk of demyelination and neurotoxicity with TNF inhibitors. They're not used in patients at all with multiple sclerosis. It's debated if it is a truly direct medication side effect or if it just unmasks the multiple sclerosis potentially earlier. These patients are maybe, say, already genetically predisposed to having multiple sclerosis, and it kind of unmasks it. I'd probably more so go with the former, that there is some true toxicity. But again, the jury's kind of out with why. We just know that we do not want to use this in MS patients. So if they have MS and then say some psoriasis, we're going to avoid TNF inhibitors completely. There's also a rare side effect of cardiac toxicity, particularly congestive heart failure. So we don't use in NYHA classes 3 or 4. You can use in class 1 or 2. I would monitor these patients carefully, probably get a TTE once a year or so, and obviously clinically evaluate them frequently as well. But if they have truly advanced heart failure, do not use TNF inhibitors. There's no data showing that it improves class 1 or 2, but at least it does not cause it to progress, but it actually can worsen class 3 or 4 and make them truly decompensated. Moving on to the idea of infections with TNF inhibitor use, when you actually look at large analyses and claims data, they actually have some of the lowest infection risks of all the biologics. The big exception is infliximab, and this very likely has to do with the fact that infliximab dosing is extremely titratable. You can go up to really, really high doses and frequency. So of course, those patients who, maybe you start on low to medium, they can get on these massive, massive doses as we try to use it to maximize efficacy. So infliximab does have a pretty high infectious risk, but that one aside, almost all the other TNF inhibitors, the data is very, very clear that they actually have a very low infection risk compared to the other biologics that we'll talk about a little bit. TNF inhibitors also are known to cause ANA positivity. So if a patient was ANA negative and then say 2 years on their medication, they're now positive, probably from the TNF inhibitor. It does not mean that you have to stop it. It just causes that lab to become positive. But there is a very rare form of drug-induced lupus that can be caused by TNF inhibitors. Super, super rare. In fellowship, I remember seeing one case that I inherited from another fellow, and then I've never seen one since. I've seen a lot of ANA positivity, but I've never actually seen true drug-induced lupus. The concerning thing about that is that it's more than just the drug-induced lupus that we see with isoniazid or hydralazine. These patients actually can develop lupus nephritis, whereas the other classic drug-induced lupus medications cause a lot of skin issues, maybe some arthritis, maybe some pleural effusions. But when TNF inhibitors cause drug-induced lupus, it's more insidious and causes lupus nephritis often as well. There's also a very paradoxical effect of causing new psoriasis. This is odd because we treat it. We use this to treat psoriatic arthritis and psoriasis. I've seen this happen once. And even when I saw that, I'm still am not sure if it was due to, because it was a man with ankylosing spondylitis, which those patients have a risk of psoriasis as well. So you have to wonder, maybe that psoriasis would have happened anyway. Maybe the TNF inhibitor uncovered it. It's hard to say, but this is a known side effect. Just until recently, probably the last 5 years or so, there was some concern that TNF inhibitors were linked with malignancies. Obviously, this would be very concerning to any provider or patient. Now that we have more data, though, particularly out of Europe, some large claims data, meta-analyses, we do not see any increased risk of cancers with patients who are on TNF inhibitors. That increased risk actually came from the rheumatology literature, from the rheumatoid arthritis literature, where the rheumatoid arthritis patients to begin with do have a higher rate of lymphoma, uncontrolled inflammation, also with lupus, higher rates of lymphoma down the line, particularly with those who've had very severe disease. And again, a longer period of uncontrolled inflammation, which are probably the patients who are going to be on the TNF inhibitor for longer. So there was a little bit of a bias in including or looking at patients who had more severe disease. But when you control for disease severity, control for past medication use, age, et cetera, we do not see any higher rates of solid or hematologic malignancies. And this is really, really important because unfortunately, when patients Google TNF inhibitors, some websites are not up to date, and it will say there's might be an increased risk of cancer with TNF inhibitors. And right now, the consensus in rheumatology is no, we do not see that. Rituximab, so this is an anti-CD20 antibody, a little bit of maybe one of our bigger guns, pretty powerful and can be very effective for certain patients, but a very high risk of hepatitis B reactivation and then subsequently fulminant liver failure if they have a latent hepatitis B. So we get hepatitis B serologies, and then also a very, very rare side effect of PML. I've never seen PML, but it is in theory a risk. And I believe the neurology world will actually get JC virus serology more frequently. We don't ever check JC virus serology before using rituximab, but I know that's something that they do in neurology. With rituximab use, we also see poor COVID-19 outcomes by far and away in all the studies looking at our medications with COVID-19. Rituximab screams out as having the worst outcomes. And again, this is with all comers, all diseases, rituximab, worst outcomes. So I wouldn't say it's fallen out of favor, but we really think long and hard about whether we're starting this medication in the midst of a pandemic. We also see a decreased response to all vaccinations for patients who are on rituximab. For sake of time, we'll move forward a little faster. We also see for most of our biologics a slightly increased risk of zoster. So I'd like my patients to get their shingles vaccines if possible before starting, and then increased risk of what's called non-serious infections. So again, sinusitis, UTI, and this tends to be the highest in the first 6 months after starting. Most of our biologics don't need stringent lab monitoring or have medication interactions. So this is why this could be a really good fit for some patients, particularly those who have polypharmacy. JAK inhibitors are one of our newest classes. Again, herpes zoster for sure, very high risk of that, even in younger patients. So I will, again, encourage patients, try to get vaccinated, even if you have to pay out of pocket for it. I've seen it enough that I would like these patients to get the new Shingrix. We'll also monitor liver enzymes, a CBC as well. And then there's some data showing that with tofacitinib or Xeljanz, there's a possibly increased risk of major adverse cardiac events and cancer, which is, of course, terrifying to our patients. So EULAR, or the European Rheumatology Body, actually recommends that you use this in what's considered low-risk patients. So these are patients who are not at high risk for cardiac events, particularly those younger than 65, non-smokers, et cetera. These are fantastic medications. They work very fast. They're very effective, particularly for patients who have failed TNF inhibitors. So we like using them, but we have to be very cautious when we do. Briefly, apremilast is a medication we use for psoriasis. I like it. It's not very immunosuppressing, if at all. No lab monitoring is needed, but for these patients, this has a very interesting, unique side effect of worsening depression. If we have a patient with a known history of suicidal ideation, we will not use this medication. All right, let's move on to some more things here regarding infections. So I've kind of alluded to this already, but by far and away, one of the biggest risk factors for a higher risk of infections is using steroids as well. Uncontrolled diabetes also. So I want patients to have their diabetes controlled when they see me for their new rheumatoid arthritis and try to get off of steroids as much as possible. Generally speaking, the conventional DMARDs will have a slightly lower risk than biologic DMARDs. Again, the exception of cyclophosphamide and using high doses of pretty much anything. So super high dose mycophenolate or azathioprine. And the risk looks like it's the highest in the first 6 months after starting a medication. This probably has to do with the really dysregulated immune system. But generally speaking, the longer patients have been on our medications, the better they do in terms of infection risk. And then we actually see less infections in lupus patients treated with hydroxychloroquine. So this is not immunosuppressing. For those patients who are on TNF inhibitors and get COVID, this was a really big issue. When I'm seeing patients during the pandemic and I'm telling them I'm starting an immunosuppressant, many of those say, I don't want an immunosuppressant, not when there's COVID-19 out there. Now that we have a lot of data, now that we're 2.5, almost 3 years into the pandemic, we very, very clearly see that TNF inhibitors actually are correlated with better outcomes from COVID-19. The worst outcomes are seen with rituximab, and then everything else kind of falls more or less in between or is neutral. But this is nice because, again, I use TNF inhibitors a lot for RA, for psoriatic arthritis, and we can pretty confidently say this will not worsen your COVID-19 outcomes. And if anything, it might actually help decrease hospitalizations and poor outcomes like that, being ventilator dependent and death, obviously, too. The literature also shows that one of the biggest risk factors for poor COVID-19 outcomes is actually poorly controlled rheumatic disease using high doses of steroids, and then, of course, the classic risk factors. So I'll explain to my patients, look, we need to start this DMARD because, let's say, adalimumab, which is a TNF inhibitor, one, it's potentially going to help if you are diagnosed with COVID, your odds of doing really well are a little higher. And secondly, we don't want your disease to be poorly controlled. That's a bad COVID outcome risk factor. And we don't want you to be on high doses of steroids. So I explained this to them. Usually then they kind of get it. They're fine with starting. But again, a very pertinent idea in the setting of the pandemic. Rituximab, definitely some of the worst outcomes. Some other medications, there's like these odds ratios of 1.15, like slightly increased risk, but some of the data for rituximab shows poor outcomes like 4 to 8 times greater than match controls not on rituximab or on another agent. So we do have some guidelines for what to do with our DMARDs and patients who get COVID-19. I have the reference here below. Oftentimes we actually don't even hear from the patients if they get COVID. They just tell us like a month later, oh yeah, I had COVID. I continued my medications. I hope that's okay. Or they'll go to their primary care doctor first, or maybe they will contact us, but we don't, by the time we get the message from the nursing staff, they're already like a week into treatment or something. So these guidelines are very much just expert opinion. They're not based on a lot of evidence, and we use them very, very, very loosely. And I think the main thing to take away from these guidelines is that we still use our DMARDs. We have not pulled back on any medications because of the pandemic. Maybe there were exceptions being rituximab, but these guidelines say treat the disease. You have a brand new patient with polymyalgia rheumatica, treat the disease. If a patient gets COVID, most of the medications are actually recommended to hold until 7 to 14 days after symptom resolution. A lot of rheumatologists debate this. So you will see patients who are told to continue their TNF inhibitor through treatment, or their IL-6 therapy through treatment, or their hydroxychloroquine. Having a year's worth of a medication and then getting COVID-19, whatever's going on with your immune system, that's already happened. It's holding it for 1 week is not going to have a dramatic effect if for their immune system to wake back up. For the majority of patients, holding a medication for say 2 to 4 weeks might make a difference. But if we're just telling them hold it for a week, it's just kind of silly from like a immunologic standpoint. So again, this is very debated, but for the most part, it is recommended to hold medications, restart after symptom resolution, after discussion with the rheumatologist. Moving on to using DMARDs in the setting of surgeries. Again, similar to infections, we see worse outcomes with concomitant steroid use. So the surgeons, of course, are very worried when they see patients come in on our medications, but I really try to drive home with both the patient and the surgeon, let's get them off of or on extremely low doses of steroids first, because that's what worries me more than these other DMARDs for the most part. So some more guidelines here. These were actually just updated. So the 2017 ones have been published, but the 2022 ones are in the midst of being published, and they're actually very similar. So I just have the 2017 ones up here. And this is for patients who are doing a TKA or THA, which are high risk surgeries and have very high rates of infections afterwards. So these are going to be extremely, extremely conservative relative to, say, getting your wisdom teeth pulled or a really simple low risk procedure. But we follow these guidelines generally. What these guidelines say, kind of boiled down, is we actually continue our conventional DMARDs throughout the perioperative period. Some surgeons will prefer that it's held. I usually do not. I try not to die on that hill. If I'm like, sure, if you want to hold it just for a couple days, restart it a week after surgery, that's probably fine. if I'm so concerned about a patient that I don't want them to hold a DMARD, they probably shouldn't get a TKA or THA then, right? If we're concerned about horrendous lupus nephritis, or they have really uncontrolled ankylosing spondylitis and they feel miserable, I'll probably want them to delay the surgery as it is. So if a surgeon wants me to hold the conventional DMARDs, I'll hold it for a little while. For the biologics, generally speaking, you just hold it for one cycle and you do surgery in the midst of that and then restart one cycle later. So if they get their let's say they're on Cimzia once a month or certolizumab once a month, they'll get it January 1st, they'll have surgery around February 1st, and then they can restart it on March 1st. So you just basically hold it one cycle, and that's when you do surgery. Pregnancy. So a lot of our patients, particularly those with lupus and rheumatoid arthritis, are women of childbearing age. So we have to address this issue very carefully and thoroughly. The vast majority of our medications have never been studied in the context of pregnancy specifically. A lot of it is just observational, retrospective data. We've also borrowed a lot of data from the gastroenterology world, since they use a lot of our same medications. We do know that some are clearly teratogenic, others we don't know, or it's really unclear. But at the end of the day, the most important thing for healthy pregnancies is to control mom's underlying disease. So poorly controlled lupus is a risk factor for poor fetal outcomes. So if the mom has to go on some steroids, if the mom has to continue her azathioprine, or let's say she was even on mycophenolate, which is teratogenic, but she was lost to follow-up and now she comes back in halfway through the pregnancy, we have to have that discussion about maybe it's better to control your disease with certain medications rather than to stop everything, have you flare and potentially lose the pregnancy. So as I mentioned, we've borrowed a lot of data from the IBD world. They have a large study called the Piano study looking at pregnancy outcomes in IBD. And it looks like TNF inhibitors are actually pretty darn safe in pregnancy. The thought is right now, continue the TNF inhibitor and then hold 1 or 2 doses before delivery versus stopping completely in the third trimester. Many of our other biologics are probably safe, but we just don't have as much data. And so if I do have a young woman who wants to get pregnant, I'll often really try to get them well controlled on a TNF inhibitor because, again, that's where we have the most data. Many of the conventional DMARDs are also safe, particularly hydroxychloroquine. That actually improves pregnancy outcomes in lupus, so I always push the patient to continue on that. Azathioprine, tacrolimus, and sulfasalazine. A thing about tacrolimus is, as I mentioned, it can cause hypertension. So we're always concerned, can we differentiate between new hypertension from tacro versus preeclampsia? And then there's some that are very clearly teratogenic: cyclophosphamide, mycophenolate, leflunomide, and methotrexate. Now, I've seen successful pregnancies on methotrexate and mycophenolate. I would never recommend that to the patient, but it's not like you're guaranteed to have a miscarriage or a congenital malformation when you're on these. Yes, there's higher rates, but it's not like a 100% slam dunk, you're going to have an issue. So we will see patients sometimes come in, they're 4 or 5 months pregnant after organogenesis, and sometimes they're continued on these medications. We do not recommend it, but it does happen. We avoid JAK inhibitors in pregnancy. And then generally speaking, for breastfeeding patients, it's pretty much the same principles here, but they're slightly more liberal given the low transfer of medications into breast milk. My son is waking up, but I think we can finish up here. Again, more nice guidelines here. These are probably the most evidence-based of all the guidelines I've presented so far. So I'm really happy that we finally have these. These just came out a few years ago, and they're actually in the midst of already being rewritten, but they're super, super helpful and very patient-centered. It goes over these topics, DMARD use, contraception, et cetera. I think this is just interesting stuff to look at for anyone who takes care of young women with rheumatic diseases. So in summary, when we use DMARDs, we want to control the disease. We want to minimize steroid use and obviously then lower steroid toxicity and improve outcomes, both from a provider's perspective and a patient's perspective. We have a lot of DMARDs from which we can choose and then combine. We do that very carefully, of course, being attentive to side effects. We'll counsel the patients for infection risk based on which DMARDs we're using. As I've mentioned, some with much higher infectious risk, some with lower, and some even somewhat protective in the setting of COVID-19. And then other things we have to talk about with the patients, again, COVID-19, what you're going to do with your medications if you're going to have an operation, and then how that relates to reproductive health and family planning. And that's it. Any questions?
Leanna, thank you very much. I'm sorry again to the audience. My Zoom is continuing to be vexatious, so I can't see myself or anyone else in the audience, but I saw Leanna's great slides, and that was a super helpful talk. I'll ask a couple of questions if you don't mind, but if anyone else in the audience, again, whom I can't see, feel free to unmute and ask away.
Let me go snag my son really quick. He just came up, which is perfect
Yeah,
timing.
you can show him off to us. For everybody who is waiting for some questions and answers, please remember to dial the number and text code 5163 to get CME credit. And we have compliments pouring in left and right to Dr. Wise. What a cute baby. I miss having ones that little, mine are all big. So we hope he's feeling better. Leanna, do you mind if I ask you a couple of questions?
Yeah, no, please. I
Okay.
mean, the more the better.
Okay, great. Well, I think one of my big conundrums, I always like to try to keep a finger on the pulse of my immunosuppressed patients, but obviously I'm not the one who is primarily monitoring, but some of the things as a primary care physician I can do is be responsible for vaccines and things like that. One practical question I have for you is that the current guidelines for Shingrix are 50 and over. What is your experience in trying to vaccinate younger patients before initiating DMARDs, for instance?
Usually insurance won't cover it and they pay out of pocket. I think I might have had one patient who could get it. I'm trying to remember if that was at the county or Keck, and I remember having to write a letter and then it was covered. I feel like every insurance nowadays is kind of different, and there's sometimes no rationale for why they're telling me to use one medication rather than another. But vaccination wise, the majority of patients have had to pay out of pocket for it. So I'll really push them to, if they can afford it, to consider that, especially with JAK inhibitors and rituximab.
Okay. Yeah, that's a fascinating one. I have a ton of patients, even not on DMARDs, who swear they want it early. And I wish all patients were so anxious to receive vaccines.
Yeah. I mean, I think, if I've seen some bad zoster on these patients, and then, patients read, and I think it's very reasonable to pay out of pocket for this. If they're going to pay out of pocket for something, oh, I want to buy this vitamin, or I want to get this or that. I was like, no, this is a good use of your money, getting the Shingrix.
Great. Again, anyone in the audience, feel free to unmute. Oh, here we go. Let's see here. Questions I usually get from the residents often relate to which room medications to stop, if any, when a patient gets admitted for an infection, colitis, pneumonia. What should be our general approach to holding medications when they are admitted?
That's a really good question. It's not a one size fits all answer. First of all, with consult room, that's a very legitimate reason to consult us while admitted. Everyone will have a different comfort threshold with continuing medications, and it depends on the infection too. So if it's a horrendous zoster, I would stop their mycophenolate, or if they're on azathioprine or something. Now, that being said, again, hydroxychloroquine, apremilast, those really are not immunosuppressing, so I would not stop those. Rituximab, once the rituximab is in their system, the only thing we can do at that point is to maybe delay it a little bit. If they're around the next time point for giving it, maybe we'll push it out 2 to 4 weeks until the infection is fully cleared. But for an acute issue, colitis, pneumonia, I think it depends on how ill the patient is. There's no perfect guidelines, and there's just not going to be a one size fits all question. Some of my colleagues are actually going to continue all medications because the rationale is they already have the infection. It's already there. So really all you're gambling with is potentially just the length or maybe the severity of the infection, which of course could be very scary. If they've had a horrible pneumonia, bad bacterial pneumonia, maybe we should stop the mycophenolate. But, if it's just again, I feel like I could just keep talking on. It's just not a one size fits all. But the way I think of it is the more severe an infection, the more likely I am to hold the medication, particularly for outpatient. If they've got a common cold, maybe a UTI, sinus infection, yeast infection, I continue right through. But yeah, if they're admitted, I'm probably going to have, there's probably a 50-50 chance I would stop the medication. If it's brand new lupus nephritis, which is really, really important to get under control quickly, I might not stop their mycophenolate or voclosporin or whatever they're on, because I'm so intent on saving the kidneys. Throw on the broad spectrum antibiotics, do a thorough infectious workup. So again, I can think of many cases where you will stop and you will continue for other ones.
Great question. Kind of related to all of these things, the earlier question I asked, and then that question, what do you see the role of internists as being in participating in these patients' care?
Yeah, that's also a great question. And again, probably not a one size fits all answer. I would say that at the end of the day, one thing that slightly frustrates me is, and I see this very infrequently at Keck. I feel very comfortable when my Keck colleagues are their patient's primary care. I see it more from outside, or maybe in the county system, like the small little county offices offsite. Is everything is very quickly attributed to the rheumatic disease or the medication. So a patient comes in, a lupus patient has a cough. Oh, it's got to be the lupus. Or, someone comes in with, a rash. Oh, it must be your new rheumatology medication. And so I think just having a good broad differential, lupus patients still get things other than lupus flares. Rashes can be caused by things other than our medications or our diseases. So assisting with that workup, because as much as we, are internal medicine trained, we can focus on the rheumatologic aspect. And I think just having a good primary care doctor that can look at the symptoms and say, yeah, it could be the rheumatic disease. It could be the rheumatic disease medication, but it also could be X, Y, or Z. And we might not think of those things as a rheumatologist. So I would say just keeping a nice broad differential, keeping us in the loop with the patients. Obviously, if you want to vaccinate them before they're, if they're due for their flu vaccine and they haven't seen us that fall or winter, go ahead and give that. But I think with just keeping sorry, little guy's coughing. I think just keeping a broad and open mind when it comes to etiology of symptoms.
That's a good reminder for all things internal medicine, probably. Yeah. Thank you.
Yeah.
And then I have one more kind of maybe left field kind of question. You made the earlier point about the benefit of statin therapy in maybe moderating or maybe decreasing risk of cardiovascular disease in these patients.
TNF inhibitor therapy?
Yes.
Yeah.
So is there any broader data suggesting the anti-inflammatory impact of statins having any benefit on primary immunologic diseases themselves?
I think Michelle Petrie's group, Michelle Petrie is a big lupus guru with Brigham. They looked at statins in lupus and they did not see it improving outcomes in lupus. Otherwise, the basic principles of statin use will be the same. I think probably what I would say then is, in our younger rheumatoid arthritis and lupus patients, we don't think of a really high cardiovascular risk, but actually one of the biggest causes of morbidity, mortality in lupus is cardiovascular disease due to subclinical or very overt inflammation. So we're fine with statin use, but unfortunately, it doesn't seem to be super immunomodulating as far as I'm aware, with lupus being the one that it's been best studied in. But if you're just trying to decrease cardiovascular risk, yes, there's definitely a role, but I don't think it's going to affect the disease state.
The primary rheumatologic disease. Okay, interesting. Well, that was a fantastic talk. I learned a ton, especially because I'm old and a lot of these things didn't even exist when I was in medical school.
I mean, there's stuff coming out constantly. Like, again, the TYK2 inhibitors, those are brand new. The JAK inhibitors, I haven't used every drug in the JAK inhibitor category. So even in the next 5 to 10 years, this is going to be old news in the next 5 to 10 years.
Yeah, well, we'll get you back before that happens for a refresher. thanks very much to everyone in the audience, and we all hope your baby feels better. He was a great audience member too. He did great.
Thank you guys for having me. Appreciate it.
Bye, Leanna. Take care.